It's a big issue and a big task to assess for dissociation. I think, unfortunately, not too many people are trained in it. And so they tend to think about dissociation as spacing out. And then if they see somebody who has blatant DID, they'll say, oh, that person has a dissociative disorder. But most patients that I see don't have those blatant symptoms. They're much more subtle. And so the question is, what are we looking for in a client to diagnose or to assess for a dissociative disorder like DID, or the lesser form we call other specified dissociative disorder? It's sort of like, I think about it as a mini DID. It's parts, but they're not quite so separate. So the question is, what are we actually looking for? We're looking for amnesia, because that is a criteria for DID. And we're not just looking for amnesia for the trauma, because lots of people have amnesia for at least parts of the trauma, including people with PTSD. So what we're looking at is we're looking for more pervasive amnesia, like, I don't remember anything between the ages of 6 and 10. That's pretty significant. Okay, or I don't remember anything about life at home. I remember school fairly well, but not life at home. And so we're looking for larger gaps. And also we're looking for, in dissociative identity disorder, we're looking for amnesia in the present. And again, if we're making a distinction between spacing out and structural dissociation, people who space out and stare at the wall can go for hours and not remember what happened because, number one, they're not present. And number two, they're not doing anything. So they can have what we might consider amnesia for 4 to 5 hours in a day. But they're sitting there doing nothing. What we're looking for in dissociative identity disorder is an amnesia that indicates one part of self is active while another part of self is not paying attention. Right? And so on one level, with spacing out, nothing is being encoded. Memory is not being encoded. But with structural dissociation, you have an encoding of memory in some part of the self, but it's not accessible to another part, at least at the moment. And so you might look for people who can remember sometimes and not at others. I think the first thing that clinicians should do if they suspect that they have a dissociative client is take a deep breath. It is not that difficult to treat dissociation. It has a bad name. There are some complications to it, but I think once you get the training, that's fine. But try not to rush into starting to explore parts right away. I've seen too many clients who have been a bit overwhelmed by that. If you really think about dissociation is about hiding from yourself. It's about not wanting to be that thing, that experience, that little girl, that memory. I don't want those things. And so to be confronted by that all of a sudden is often quite overwhelming for clients. So I would suggest to therapists just to go slow, talk a little bit about dissociation in general, try to get clear in your own head some of the distinctions between ego states and dissociative parts, because it's pretty easy to confuse those if you don't know a lot about dissociative disorder. Take your time and let the client take his or her time. And so there is some literature out there about mapping the system. let it unfold like the onion layers, like we do with all other kind of psychotherapy, not diving in too quickly. And yes, we don't want to just hang out forever, but I think beginning to explore how does the client feel about talking about it. Because what I notice for many clients is even asking them about dissociation or giving them a kind of assessment instrument for dissociation creates all kinds of freeze and shutdown and flight kinds of experiences if they're unable to even talk about it without going into a big reaction. Then you know you have to slow down much more. On the other hand, you will see clients who talk about it just fine and they go home and fall apart or self-harm. Those people are more depersonalized in session. And they're kind of talking about it from here up, not aware of the reactions they're having. And so we really want to be clear that a client can accurately report how they're doing when they're talking about something, and really track carefully their physiological reactions in the session.